Our final speaker is Jamie Perrin who is a senior scientist at the Johns Hopkins Bloomberg School of Public Health. And Jamie has focused on a wide range of topics, including biostats, longitudinal data, child mortality, and child growth, among others. And, we'll be hearing more about thinking about cause-specific mortality from verbal autopsies as the kind of theme of this session. So join me in welcoming Jamie.
Thank you, Josh. Thank you for that introduction. And thank you, everyone, for staying for the last session on the last day. It's lovely to be talking to you about my research. I'm here representing my amazing research group from Johns Hopkins and the University of Alcalá and the University of Barcelona. And also, this is joint work with the World Health Organization. So I'm going to be talking today about incorporating the bias of verbal autopsy studies into the estimation of causes of death. And actually, it's thanks so much to Tyler and to AB, two amazing researchers. I'm humbled to be following you guys, and it's also very lucky for me that they have already been talking about verbal autopsies, because my research group we're kind of like a consumer of verbal autopsies, as I will explain. So the CA code it's a collaboration of researchers, and our objective is to estimate the causes of death for every country in the world for kids under 20 years of age. So the way that we organize that broadly is to separate these age groups. So today, I wanted to mention that our research group, we produce these estimates for all age groups for kids under 20, but I'll be talking today about kids under 5. So for child mortality, almost every country in the world, primary data about the level and the mortality rate for kids under 5 is being collected. You see these. This is from the UNICEF website, who is one of the producers of under 5 mortality rates, estimates of those rates. So countries will have, they might have vital registration, they might have household surveys or censuses happening. And so there's, on the ground evidence about what's happening for the levels of child mortality. But if we don't know the causes of mortality, then we don't know what interventions kids need, and we don't have enough information to act on. So that's where CA code comes in. So we're trying to fill that gap, because many countries in the world, as we saw in Abby's talk with his beautiful map of countries that are having high quality registration, which is documenting for every individual or most individuals what the cause of death was. So here, for our green and pink countries, there are decent vital registration systems that are recording causes, and in the other colors, we might have some limited vital registration information, but it's not of high coverage or of high quality. So, or there might not be any vital registration happening at all. So there's essentially no information about the causes of mortality. So our solution to this is to look into the public information and the public health literature, and to pull what has been released for one-off studies or for small areas about the causes of death. And those studies, because they're in areas where many people don't die in facilities, those studies are based on, or that cause of death information is based on verbal autopsies, which we've had a beautiful discussion of in Tyler and AP's talk. So we're not conducting verbal autopsies, but we're pulling the summary of the verbal autopsy studies and many studies over many years and across different settings. And then we're trying to extrapolate those to areas, to all those countries, the blue countries here. So to settings where verbal autopsy studies haven't been done. So this is just a broad representation of our work. We're conducting a systematic review to pull verbal autopsy studies. We're working with HGSS sites and large household surveys that are conducting verbal autopsy studies. And we're bringing in some specific estimates of causes that are very hard to measure in verbal autopsies, like HIV and tuberculosis. And then we're putting them all together to estimate child mortality. So just, I'm not going to go into a lot of detail, but we've been producing these estimates and refining our methods for almost 15 years now. And so we have a process that we've developed for these high mortality settings where vital registration isn't available. So we conduct our systematic review, put together this verbal autopsy data for kids by age. And then we're using a multinomial regression in the Bayesian framework. And then we have a collection of covariates information about the health system, what's happening in countries, and we pick which ones are important with the lasso. And then we use out-of-sample cross-validation to pick the parameters for the lasso. And then we let countries that have big studies, we use random effects so the studies can be informative for the country's estimates. So one of the known weaknesses of this approach that has always been on our minds was the limitations of verbal autopsies. And that's something that we've argued about and discussed for many years, and that verbal autopsy is a difficult instrument. It's conducted in difficult circumstances, and it's cause of death is a very difficult thing to measure when deaths occur in people's homes and without any diagnosis, no medical expertise. So now we're trying to address that. Actually, this is also related to Tyler's talk. So the regression coefficients that Tyler was talking about that were estimated with error when a prediction was used that is flawed. Those are we're estimating coefficients with verbal autopsy data. So we knew there was error. But for a long time, there wasn't anything that we could do about it. Oh, so here's, I borrowed this slide from a collaborator, Abby Dada. This is just a representation of verbal autopsy, the verbal autopsy process. So we started working with another group of researchers friends from Johns Hopkins. And there's actually some overlap. Bob Black and Lee Lu, actually Lee's here, is our leading CA code. We're also, we started working with a group of researchers in the Department of Biostatistics. And these are actually the AI researchers that we collaborate with. And they were working with a very high quality verbal autopsy study where verbal autopsies were being conducted for kids under 5. And for the same deaths, these minimally invasive tissue sampling was conducted as a sort of autopsy. Actually, there's probably experts here on the CHAMPS study. So this is the CHAMPS data where we had a gold standard causes of death for kids, as well as verbal autopsies. So this group of researchers from biostatistics were able to estimate the biases from verbal autopsy for kids under 5, and also to look at the bias as a function of the verbal autopsy algorithm that was being used and the setting where the verbal autopsy was conducted. So, and actually this work is also funded by the Gates Foundation. So this, we heard that this was going on and we thought, this is amazing. We have to find a way to incorporate this in our estimates because we needed an estimate of the bias of verbal autopsies so we could make a correction for it. And now someone is producing that. So this is just more information about the CHAMPS study. So the CHAMPS study, verbal autopsies are conducted on kids, and also tissue sampling. And then there's a panel of physicians who examine the interview as well as the autopsy results. So very high quality, not quite medical registration, but almost like a medical registration cause of death is arrived at, and then the bias is estimated. And this is an example. This slide is also from Abby data, just of the estimated. This is what the estimated bias in the verbal autopsy looks like. It's it's quite dense, and it's a complex measure because for every cause or for every diagnosis, there's a true diagnosis, but then there's a selection of other possible diagnoses. So the way that a verbal autopsy could be biased, we represent that as a matrix. And sometimes I'll refer to it here as the misclassification matrix. So our first thought was, so we have this, access to this amazing estimate it's estimated from AI about the bias. How do we use this? How do we incorporate this so we can make better cause of death estimates? So do I have a pointer here? Oh, it's not very bright, but so this is our multinomial regression parameter matrix. So these are what we would use to extrapolate our data onto new settings. And so one possibility, and this was our first idea, was that so we have, this is what this bottom here is what we were currently using in our Bayesian regression. Could we include the top equation also with our misclassification and in our Bayesian model? So then it's sort of integrated into that regression. So we're correcting for the bias at the same time that we measure our regression coefficients. And there seemed to be several advantages of that. It was you're directly incorporating the uncertainty in the bias, which was very nice. It was very elegant and easy to represent. It was in a single framework. But it was hard to see what was happening. The misclassification matrix was operating in this framework, but we couldn't see. It was difficult to see what the influence was, and because there was a potential for some studies to be impacted more by this bias than others. So how could we know which ones, just what was happening exactly? So we came up with another way to use this, which was to change our process of data handling. So we're collecting data from a systematic review. So we decided to try, as an alternative to this integrated elegant approach, to try incorporating the bias correction into our pre-processing, which was it was very available to us and transparent for each study. We could see what was happening. It was less elegant than the integrated approach, and the uncertainty. We haven't quite worked out the uncertainty yet, but the transparency for us, it's very important within our group. And also to be able to share with partners and collaborators. Really, transparency has it's just high on our list of priorities. So we've decided to go with this second approach. So this is just an example of a few studies where what the calibration or the bias correction looks like. So the stars here are the original, uncorrected causes, and the green is the distribution of the true cause. So this is for neonates, and also, so we have there's separate biases and causes for older children under 5. So for every distribution that we see from verbal autopsy, there's a whole range of possible true causes, but there's also a most likely true cause-specific distribution, which is what we've taken now to put into our framework. So I'll just go briefly through a few results of that. So these are our regression parameter estimates. So on the left is with the uncorrected verbal autopsy data, and on the right, that is the bias corrected regression, or the regression coefficients after correcting for the bias. And these weren't as different as I thought they would be. And I was expecting, going into this, we were trying to anticipate the direction of that the bias would introduce, if we would be overestimating our relationships or perhaps underestimating. Going into this, I thought they would be underestimated, but then looking at Tyler's, from Tyler's talk, it seemed like maybe, at least in that situation, the associations were overestimated. So here's another representation of that. And I thought these aren't as bad as they could be. I mean, looking at, of course, we have many of our coefficients are close to 0, and that's not unexpected given that we're using the lasso, which constrains parameters so that only the most important ones come out. So here, really, so we do care about the coefficient estimates, and we look at those as a check for ourselves. So to see that everything is making sense. But really what we care about most is the estimates that those parameters yield for specific countries. So what happened? I did? Does that mean my time is up? Oh, what was it? It's a dance party. Okay.
You can finish your thought.
Okay. I can tell you that, oh, beautiful. You start talking and the picture comes up. Oh, let me go back. So I have two countries. No? Oh, okay. So here are two countries, Nigeria and Tanzania. They both have large household surveys, a population representative that have verbal autopsies. So even though regionally we didn't see a big difference in the estimate, these countries happen to have bigger differences than others in their cause estimates. And we're actually happy to see this because we're giving those surveys extra influence. So we expect if those surveys were corrected, then the regression coefficients as well as those surveys have an influence on these estimates. So this is not unexpected. And these are high mortality countries, high priority countries for programs. And these are two also large priority countries where we don't have national verbal autopsy studies. So these are the changes just from those regression coefficients and not from any additional surveys. So in summary, some of our estimates are greatly impacted by correcting for biases, especially those with large national surveys. And we feel that these cause estimates are improved by making these bias corrections, which is supported also by Tyler's work. And we also, this is preliminary results. We still have some things to work out, including uncertainty. And thank you so much for having me. Thank you to IDM and also to the Gates Foundation for supporting our research.
Thank you so much. So I think we have time for one quick question. I have a question if no one else does. I'm curious your take on thinking about the confusion matrix between CHAMPS and VA, but integrating the kind of extra information CHAMPS provides around the causal chain. So the VA predicted, primary cause. If how you would potentially integrate more of that CHAMPS data, and if that would increase accuracy, or if your team has thought about that at all.
Yeah, the group that developed the confusion matrix, they have been looking at that. So they have estimates. They have estimates of bias that are incorporating that somehow, and they're very complex. I honestly don't understand them. It's hard for us to use them because the way that we get verbal autopsy data is often, and generally, it's not at the individual level. It's like at the study level. It's like what's in the paper. Even from HGSS sites, unfortunately, we often don't get the individual data.
Great.
That's a great question.
Yeah. Wonderful. Well, let's thank all of the speakers again.